Welcome to the deep dive. You're probably tuning in because cyclical vomiting syndrome, CVS, is something you need to get your head around, maybe for the MSRA, perhaps.
That's right. And our aim today is really to, dissect it, pull out the really key info you need, and make sure it actually sticks for recall.
Exactly. Consider this your high-yield, focused session on CVS. We want you to walk away feeling confident about it.
So we'll be covering quite a bit the definition, what might cause it, risk factors, the pathophysiology, what's actually happening in the body.
And importantly, how to tell it apart from other things.
Yeah.
The differentials. Plus, epidemiology, how it presents clinically.
The investigations, management, prognosis, and any potential complications.
And we'll throw in some mnemonics and memory tips as we go, just to help lodge it all in your brain.
Sounds good. So ready to jump in?
Let's do it. First off, the basics. What is cyclical vomiting syndrome?
Okay, so fundamentally, it's a condition where someone has these recurrent, pretty severe episodes of vomiting. They tend to happen at sort of regular intervals.
And it's not just vomiting, right? There's usually other stuff, too.
Exactly. Intense nausea is almost always there, often abdominal pain, sometimes headaches as well.
And it's often thought of as a childhood thing, but not exclusively.
That's a common misconception. It definitely affects children more often, but adults can absolutely get it too.
The defining thing seems to be that pattern, these really intense bouts lasting hours, maybe even days.
Followed by periods where the person feels completely fine, totally back to normal. That cycle is the absolute key.
Right. So what about the why? The etiology. What do we know about what causes CVS?
Well, this is where it gets a bit tricky. The exact cause isn't fully understood, frustratingly.
Okay, but there are theories, right? Leading ideas.
Yes, one strong suspect is some kind of dysfunction in the autonomic nervous system, the body's automatic control system.
The one handling digestion, heart rate, that kind of thing.
Precisely. And alongside that, an imbalance in neurotransmitters, those chemical messengers in the brain, seems important. Serotonin in particular often comes up.
Interesting. And is there a genetic link?
It looks like it. There's often a family history of migraines, or even CVS itself suggests some people are just more predisposed.
Okay. And then there are triggers you mentioned, things that set off an episode.
Yes, triggers are a big part of the picture for many people. We'll definitely delve into those more later.
It makes sense. So linking into that, who's more likely to get it? What are the risk factors?
Well, that family history we just mentioned, migraines or CVS in the family, that's a big one.
Okay.
And interestingly, a personal history of migraines seems to increase risk too, even motion sickness potentially.
Really? Motion sickness?
Yeah, it seems to crop up in the associations. And then there are psychological factors, things like anxiety, depression, they've also been linked.
Okay, so quite a mix. Can we have a memory tip here, maybe for those risk factors?
Sure. How about thinking of the M's? You've got migraines, family history, and personal, and then mood for anxiety and depression.
M for migraines and mood. Got
Yeah.
it. That should help lock those in.
Hopefully. So let's move on to the pathophysiology, what's actually going on biologically.
Right, the mechanism behind it all.
So building on the etiology, that dysregulation of the autonomic nervous system seems central. Like the body's internal wiring is sending faulty signals.
And the neurotransmitter imbalance, the serotonin thing, that plays into it how?
The thinking is that this imbalance leads to abnormal signals being sent to the digestive system. And those signals basically trigger the intense vomiting.
So it's a brain-gut communication issue, essentially.
In a way, yes. Though it's crucial to say, the really fine details, the exact sequence of events, that's still being actively researched. We know the key players, but not the whole playbook yet.
Understood. Now, because vomiting is such a common symptom, differentiating CVS is vital. What are the main differential diagnoses we need to consider? It's a long list, isn't it?
It is, yeah. You really have to rule out quite a few things. Top of the list maybe is GERD, gastroesophageal reflux disease. That can cause recurrent vomiting.
Okay. What else?
Then there's cyclic vomiting that might be directly linked to migraines, which is slightly different from CVS itself. Various general gastrointestinal disorders need thinking about. Metabolic disorders, too.
Right. And psychogenic vomiting, where it's more psychologically driven.
Definitely consider that. Also, inflammatory bowel diseases, Crohn's, ulcerative colitis. And as we said, migraines themselves, sometimes the vomiting is the main feature.
Okay. Still going.
Yep. Need to think about endocrine things, too, like Addison's disease. diabetes, particularly with ketoacidosis, even rare things like pheochromocytoma.
Pheochromocytoma, okay.
And one that's increasingly recognized now is cannabinoid hyperemesis syndrome. That's linked to chronic cannabis use.
Yeah, okay. That is a lot to keep straight. Any way to maybe categorize them mentally?
Yeah, that can help. Maybe think in broad categories like GI problems, neuro problems like the migraines, metabolic issues, psychogenic, endocrine like Addison's, and substance-related for the cannabis one.
GI, neurometabolic, psychoendocrine substance. Okay, like a checklist. That helps break it down.
Exactly. Just a way to make sure you've covered the main bases.
So let's talk epidemiology. How common is CVS, particularly in the UK?
Well, it's generally considered pretty rare, so getting exact prevalence numbers is difficult.
But we know it mainly affects kids.
Primarily, yes. The typical onset is often somewhere between ages 3 and 7.
But adults get it too, you said. Is there a gender difference there?
It does seem to be diagnosed more often in adult females compared to adult males, though it occurs in both.
Okay. Now, let's get into the clinical picture. How does it actually present? What are the signs and symptoms?
The absolute core feature, as we keep saying, is those recurrent, severe vomiting episodes that follow a pretty predictable pattern for that individual.
Stereotypical episodes, they call them, right?
Exactly. And alongside the vomiting, you nearly always get that intense nausea, often visible signs too, like sweating, looking really pale.
And the vomiting itself, how long does that usually last within an episode?
The actual bouts of vomiting within an episode might only be, say, 20-30 minutes at a time, but they can recur frequently during the episode phase.
And the key thing, again, between episodes.
Back to normal, feeling well, that return to baseline is critical.
Are there other symptoms that can crop up?
Yes, definitely. Things like weight loss can happen, reduced appetite, tummy pain is common, sometimes diarrhea, feeling dizzy, light sensitivity, photophobia, and headaches are often associated.
Right. And there are distinct phases within the cycle, aren't there?
Yes, understanding the phases can be really useful. Typically, there's a prodromal phase.
The warning phase.
Kinda, yeah.
Right.
That's where you might get the intense sweating, the nausea really ramps up, the paleness. It signals an episode is coming.
Then the vomiting phase itself.
Right. That's the peak of it, the vomiting, retching, ongoing nausea.
Right after that.
Comes the recovery phase. Vomiting stops, or at least significantly reduces. Appetite might start to return. Energy levels pick up.
And finally,
The well phase, symptom-free. Could last weeks, could last months, until the next cycle starts.
got it. Now, triggers. You mentioned these earlier. What kind of things can set off an episode?
It varies a lot between people, but common ones include emotional stress or anxiety. Infections are another big one, particularly things like sinusitis.
Food triggers.
Sometimes, yeah. Classic ones people report are things like chocolate, cheese, MSG monosodium glutamate.
Okay. Anything else?
Yeah. Prolonged fasting, getting dehydrated, hot weather for some people, hormonal changes like menstrual periods, even things like excessive exercise or not getting enough sleep.
So quite a diverse list. It must be hard sometimes to pinpoint the exact trigger.
It really can be. And the severity varies too. Some episodes might be managed at home. Others are severe enough to need hospital admission, maybe for fluids.
Right. That symptom-free period, though, weeks or months, is pretty characteristic.
Definitely.
So moving on to diagnosis.
Mm.
How do doctors actually confirm it's CVS? What investigations are done?
Often the diagnosis relies heavily on the clinical picture, that classic history of recurrent, stereotypical vomiting episodes with wellness in between.
But you still need to rule other things out.
Absolutely. So investigations are mainly aimed at excluding those differentials we talked about. For women of childbearing age, a pregnancy test is usually standard early on.
Makes sense. And blood tests.
Routine bloods are pretty standard. They help rule out metabolic issues, infections, check electrolytes, assess general health. But there usually isn't one specific blood test for CVS.
Okay. Are there formal diagnostic criteria?
Yes, there are. Sets like the Rome criteria exist with slightly different specifics for children and adults, but the core ideas are similar.
What do they generally involve for kids?
For children, one common set requires at least 5 episodes total, or maybe 3 episodes in a 6-month period. The episodes need to involve intense nausea and vomiting, lasting from an hour up to maybe 10 days, and they need to be at least a week apart.
And the pattern has to be consistent.
Yes, a stereotypical pattern for that child. Vomiting usually needs to be quite frequent during the episode, say at least 4 times an hour for at least an hour. And crucially, full return to health between episodes and ensuring it's not better explained by another condition.
Okay. And for adults, similar themes.
Similar themes, yes. Stereotypical episodes, usually acute onset, lasting less than a week, typically need 3 or more episodes in the past year. Again, that complete absence of nausea and vomiting between episodes is key.
And ruling out other causes.
Yes, ruling out relevant metabolic, GI, or central nervous system disorders is fundamental to the adult criteria, too.
Right. So once you have the diagnosis, how is CVS managed? What's the approach?
Management really needs to be tailored to the individual. There's no single magic bullet, unfortunately. A big part of it is often identifying and then avoiding known triggers.
Like those foods or stress management, getting enough sleep, staying hydrated.
Exactly. Lifestyle adjustments can make a big difference for some people.
What about medications? Are there preventative options?
Yes, for people having frequent episodes, maybe more than one a month, prophylactic treatment might be considered. These are meds taken daily to try and reduce how often episodes happen or how severe they are.
What sort of medications are used there?
Options can include things like amitriptyline, which is an older antidepressant, propranolol, a beta blocker often used for migraines, or topiramate, an anti-epilepsy drug also used in migraine prevention.
Okay. And what about treating an episode when it's actually happening? Acute treatments.
Yeah, abortive treatments. The goal here is to stop or shorten an episode once it starts. Anti-sickness meds like ondansetron or proploperazine are often used.
And sometimes migraine treatments.
Sometimes, yes. Triptans, which are common migraine abortives, can sometimes help in CVS episodes, especially if there's a headache component or a known link to migraine.
And supportive care is vital too, I imagine.
Absolutely crucial during an acute episode. Things like IV fluids if they're getting dehydrated, pain relief if needed, just managing the symptoms and keeping them comfortable.
And family support.
Hugely important, especially for kids, having that support network. And also, assessing and managing any coexisting anxiety can be really beneficial, as anxiety can be both a trigger and a result of having CVS.
Makes sense. So what's the long-term picture? The prognosis for someone with CVS?
It's quite varied, actually. For some, particularly children, the episodes might lessen over time and eventually resolve, often around late childhood or adolescence.
Not always.
Not always. Others might continue to have episodes into adulthood, although effective management and trigger avoidance can often significantly reduce the frequency and severity.
So regular follow-up is key.
Definitely important for monitoring, adjusting treatment plans, and managing any complications that might arise.
Oh yes, complications. What are the main risks associated with having recurrent severe vomiting?
The most immediate ones are dehydration and electrolyte imbalances, just from fluid loss. In children, prolonged or severe CVS can sometimes impact growth, leading to weight loss or what we call failure to thrive.
Anything else?
Dental erosion is a concern. The stomach acid repeatedly coming into contact with teeth. And then there's the psychological impact.
The distress and anxiety.
Exactly. It can really affect quality of life, social functioning, missing school or work. It takes a toll.
You mentioned earlier that childhood CVS often resolves. Is there anything else notable about the long-term outlook?
Well, that potential link to migraines later in life is interesting. About half of children with CVS might go on to develop migraines. It suggests some shared underlying mechanism, perhaps.
So prevention strategies kind of overlap with management. Good sleep, stress management, avoiding triggers.
Pretty much, yes. And for some, especially those with that migraine link, migraine preventative medications might be considered as part of the strategy.
Okay, so just to recap those complications. Dehydration, electrolyte issues, potential weight loss in kids, dental problems, and the significant psychological and social impact.
That covers the main ones, yes.
Right, well, we've certainly covered a lot of ground on cyclical vomiting syndrome today. From the definition, causes, risk factors, right through mechanism differentials, presentation, diagnosis, management, and outlook.
Hopefully breaking it down like that has helped clarify the key points for your revision. Remember those little hooks like the M's for risk factors?
Migraines and mood.
And the categories for differentials: GI, neuro, metabolic, psycho, endocrine, substance. Little things to aid recall.
Definitely helpful. And perhaps something to think about as you continue reviewing that whole gut-brain connection. With conditions like CVS and migraines seeming linked, what might future research uncover there? It's a fascinating area.
It really is. And for more revision help, don't forget to check out PassThemMSRA.com.
And also freemasturate.com for additional resources. Both great sites.
Absolutely.
Well, thanks for joining us on this deep dive into CVS. We hope it's been useful for your preparation. Until next time.